Dr. Daver, for newly diagnosed AML patients, what are the latest and most promising available therapies?
For newly diagnosed AML, at this time, the most promising agents include targeted therapies and BCL2 inhibitor-based treatments. These are non-chemotherapeutic drugs, and we've seen great progress in the application of these, as well as recent FDA approval. So one of these is an agent called venetoclax. This is a BCL2 inhibitor, and venetoclax in combination with hypomethylating agents such as azacitidine has shown a response rate of close to 75%. And the nice thing is that this regimen can be given in patients who are older than 70, 75 years of age, and even those who are having comorbidities or not fit for traditional intensive chemotherapy with similar response rates. So this has been approved in the last couple of years for the frontline treatment of older unfit AML. And we've been using this combination of venetoclax azacitidine frequently with high efficacy in this patient population. The other new agents that have shown breakthroughs in AML are the targeted therapies. These include FLT3 inhibitors that target the FLT3 mutation. And these have shown good activity both as single agents, with gilteritinib being approved in the relapse refractory setting as a single agent, where gilteritinib showed a response rate of about 50% as a single oral targeted therapy in relapsed FLT3 mutated AML, which is actually better than the response rate with high dose combination chemo, where the response rate is only about 25–30%. So gilteritinib is now approved, and it's now moving and being evaluated in frontline setting. Other FLT3 inhibitors like quizartinib actually just recently completed frontline studies showing improved outcome when quizartinib was added to intensive chemo versus just intensive chemo in FLT3 mutated AML. And we hope and think there's a good chance quizartinib will be approved in the near future. And also IDH inhibitors have been approved both in the relapse setting, frontline setting, and now we even have a third group of targeted therapies called the menin inhibitors that target MLL rearrangement and NPM1 mutations, which are seen in about 15 to 20% of AML. So there's been a lot of progress, all of this in the last 7 years, 6–7 years, with multiple targeted therapies, multiple BCL2 inhibitor-based treatments showing progress in AML. And then also recently, the concept of maintenance therapy. This was something we used for the last couple of decades in acute lymphoblastic leukemia and in multiple myeloma and in lymphoma, but we had not had clear data in AML. But the recent study using oral formulation of azacitidine CC486 has shown that maintenance in patients who completed induction consolidation and could not go to allogeneic stem cell transplant for one reason or the other was important and improved both overall survival and relapse-free survival. And so this is the first time now we have an FDA approved and standard use of maintenance therapy after the traditional induction consolidation. So even changing the general paradigm of AML therapy. So a lot has changed in the last 7 to 8 years in the treatment of acute myeloid leukemia, and this is very exciting. And the activation tip related to this question is that there are multiple new targeted and low intensity therapeutic options available for patients with acute myeloid leukemia. And in our institution, in my opinion, even older patients are eligible for some form of therapy or the other. Very few patients, if any, today are being sent to hospice or palliative care without treatment. So it's very important to really consider all the available treatment options, and if needed, seek consultation with an expert or academic center to get the most up-to-date treatments available for AML.